So my name is Jessica Levin, and I'm the Chief Program Officer of Let's Talk Menopause. And Let's Talk Menopause is a national nonprofit changing the conversation around menopause so women get the information they need and the healthcare they deserve. Our menopause talks are central to our education efforts, and you can find 25 of them on our website at letstalkmenopause.org under programs. And all our menopause talks are for information purposes only, so not as a substitute for professional medical judgment, diagnosis, or treatment. And before we start, we want to let you know that the chat is for us to put in links for you. We are not going to tag questions and answers on the chat, so please put them into the questions and answers. We are going to try to get to as many questions and answers as we can today. So the chat, again, is closed. There also will be a very brief survey at the end of the talk, and we really would love you to give your feedback to us so we can continue to improve our offerings. So I am happy to introduce Dr. Kristi DeSapri. And I just have to say, she is a national leader in the field of osteoporosis and menopause management. And when I told people, doctors, researchers, we want to dive into bones more thoroughly, the name that came up again and again is Dr. Kristi DeSapri. After a fellowship training at the Cleveland Clinic, she has worked in private practice and academic medicine. And I do have to read her. She was the director of Northwestern Women's Bone Health Program at the Center for Sexual Medicine and Menopause at Northwestern Medicine in Chicago. She's the founding physician and owner of Bone and Body Women's Health, a specialized midlife women's health practice in Winnetka, Illinois. So we want to thank you so much for being with us. We are thrilled you're here today. Just to give you a thank you, Dr. DeSapri.
Yeah, I'm so excited. Thank you, Jessica. Such a nice warm welcome. And I love the number of attendees we have. So that's amazing. Well, I can't wait to have this discussion.
It's great. So I just wanted to give everyone a roadmap of where we're going in this talk. There are 5 sections before we're going to have questions and answers. The first section is definition of osteoporosis and osteopenia. Oh my God. Hold on one.
Oh, she's got her dog.
I apologize for that. My dog sneaks back in when I'm not looking. We're going to do definitions and diagnosis. Then we're going to do risk factors. We're going to talk about prevention, treatment, and then we have 2 scenarios that we think a lot of people will be able to relate to. So I first wanted to start, Dr. DeSapri, by you telling us, why do we need to care about bone health and bone disease?
Mm-hmm. Thanks so much, Jessica. So this is such a loaded question and so important, especially for obviously all of you captive here today. You obviously care already about your bone health, or you have been diagnosed, on the continuum of, osteoporosis or osteopenia, or maybe even have risk factors or family history of these conditions and want to prevent that. So I think the most important reason we should think about bone health and prevention of osteopenia and osteoporosis and treatment of those conditions at the time of midlife is that many women, like most of us probably on this call, will live into our 80s or beyond, and will live 30 to 40 years past the time of menopause. And we know that menopause is significantly a sentinel event for many things, like cardiovascular disease, like changes in our metabolism, and our bone health is one of the ones that's dramatically changed at the time of menopause, particularly with the loss of estradiol or estrogen from our ovaries. And so we know that, again, if we're living long enough and we want to live strong enough with our bones, with our muscles, preventing falls and fractures, bone health is of paramount importance.
So I want you to define osteoporosis for me. I know I am 59. I know a number of women around my age who heard about osteoporosis for the first time when they were diagnosed with it. So
Mhm.
can you define it for us,
Sure.
and tell us how you diagnose it?
Yeah. So I think the term, remember, osteo means bone and porosis means thin. And so we really, when we think about osteoporosis, we think about thinning or deterioration of the bone mineral density, the bone quality, which is then contributes to the bone strength. And the sort of the end product or the end outcome that we're trying to prevent with osteoporosis is a fracture. So in fact, osteoporosis can be defined a couple ways. It can be defined on a DEXA scan, which is the best sort of screening tool we have for bone mineral density and bone strength by looking at our spine, our hip, and sometimes our forearm. Another way that osteoporosis can be diagnosed is by a fracture. So a low trauma fracture or a fracture from a standing height or less, things like a wrist fracture, a hip fracture, a clavicle fracture, ankle fracture, patellar fracture, and other vertebral fractures. So these signs of fractures actually are very important and can help us diagnose osteoporosis, or at least put on some alarm signal that we need to evaluate our bone density and our bone health at that time. And so really that's what the main two ways. And so I think many women don't realize the DEXA scan is freely available and so easily accessible. And the T-score, or sometimes even the Z-score diagnosis that we use, really helps to frame where you are in the continuum of normal bone density, comparing your bones to someone of a peak bone mass, or osteopenia, generally defined as a T-score of minus 1.1 to minus 2.4. And sometimes those levels can be up or down based on our bone quality, or something called the trabecular bone score. And
Wait, I
osteoporosis
have to
is,
stop you for a
okay,
second
stop me.
because a lot of our audience, I want you to break these things down in their component parts for me,
Sure.
because I want you to start by telling me and the audience, what is a DEXA scan?
Mm-hmm. So, and yeah, if we had a show of hands, I would be probably about 50% or more have had a DEXA scan or are trying to think about getting one. So what a DEXA scan is I sort of say it's sort of like, you know, how we do a mammogram at our baseline, and now that's recommended at age 40 to understand our breast architecture, see if there's any masses, do a, you know, risk assessment for breast cancer. A DEXA scan is very similar for bone health. This is a low risk, low radiation screening test. So screening for our density, our quality of our bone, and our strength. And we scan the two areas. So we scan our spine, which is primarily made up of trabecular bone. And actually every bone in our body is made up of two different types of bone. Trabecular bone is one that's generally found on the inside of our bones and turns over, or we call that, you know, the bone world remodels more quickly. And so we look at the L1 through L4 vertebral bodies so we can assess, again, the composite bone mineral density in that area. And then we also look at our hip. Generally, looking at both hips is important. This hip bone density, we can look at the total hip, and then another compartment called the femoral neck, which is actually the inside area of the hip, which is, again, comprised of both trabecular bone, but a different type of bone actually called cortical bone, or the sort of the longer, stronger bone that's outside of all of our bones, including our long bones like our hip, our forearm, etc. And so that, with those two values together, sort of gives us a good snapshot of what every single bone density and bone quality looks like in all of the other bones in our body, and helps us determine many things. Number one, strength, but also helps portend the risk of a fracture. A bone mineral density is important. It's one important part, but there's many other important parts, like we'll talk about that in a minute, like our clinical risk factors, like our age at menopause, ethnicity, the peak bone mass that we accrued, etc.
So I just want you to also explain very simply, because it took me a while to even understand this. So in the most layman terms you can, what the Z-score and the T-score mean.
Yep. So, so when we look at, you know, any sort of normal, when we have to sort of figure out in medicine, right, we like to put things into categories to understand, you know, how, what is our risk for things. Like when we look at maybe the cholesterol panel, we know that a total cholesterol over 200 is high, but we have to look at the HDL and the LDL. Very similar when we look at a DEXA. We look at the T-score, which is basically a standard deviation, which means that how far have your bone mineral density deviated from a peak bone mass. So someone who is maybe in their 30s, who's achieved a normal peak bone mass based on, again, large scale data that have been done and validated from the World Health Organization, the NHANES or National Health and Nutrition Survey database. And we actually have that listed for each decade of life, as well as different ethnicities, races, etc. So when we use a standard deviation, it tells us, looking at your density today, at your age, race, sex, how far off are you from a peak bone mass? And for some women, and this is where the discussion gets a little bit tricky, is when we do a bone density at baseline, sometimes that's all the bone that they had to start with, right? And so they might start with a lower peak bone mass compared to someone who might have a normal peak bone mass. And then we see that over the years, the T-score can deviate from normal. And we know that with every decade of life, we can see different decreases. We can see sharp decreases in the bone mineral density at the time of menopause, again, from sex, estrogen losses. Your Z-score, which is, again, when you look at the jumble of numbers on the bone mineral density, it looks at the Z-score is one generally all the way on the far right, which compares your bones to someone of a similar age, race, and sex match. And we usually actually, most of the organizations that validate DEXAs, like the International Society of Clinical Densitometry, really recommends we use Z-score mostly for women who are in the pre-menopause or before the menopause transition. However, it gets reported for all of our, patients, and sometimes that Z-score, when it starts to drop below minus 1.5, means that it's further from, the similar age, race, sex match. This tells us sort of, again, another alarm sign or sort of another alert that we should be looking into why that is. Could that just be, again, genetics, or could it be a secondary or underlying cause, meaning your bone density is deviated from your peers?
So we have a number of questions, and we're going to take most of our questions at the end, but this is very related to our next topic around risk factors, but a number of questions around when do you get a DEXA scan?
Mm-hmm.
And you said it was relatively available and easy to get.
Mm-hmm.
A lot of our audience, though, may not be offered a DEXA scan till they're 60, and insurance policies often say 65.
Mm-hmm.
You said something very interesting to me. You said that if you have one of a number of risk factors, you can make the case to have an earlier DEXA scan and get it covered by insurance.
Correct.
So can you explain to me what those risk factors are?
Sure.
And how that affects your decision about whether to request a DEXA scan?
Right. So I think that's right. In the world of insurance and medical guidelines, it's quite shocking to many women, including pretty much all the patients that I see, that, we recommend a DEXA at age 65. However, for, all comers, all women. However, we know that, at the time of menopause, as I've said now, this will be my third time saying that, we lose estrogen, and that's being female and being postmenopausal are just two risk factors that I always say these are non-modifiable risk factors for losing bone mineral density. And then we stack on some other risk factors like family history of osteoporosis or fractures, particularly in a first degree relative like a maternal or paternal hip fracture, or a known, risk of kyphosis or losing height and vertebral fractures. I mean, many people are starting to understand these and recognize these in their mothers or in their grandmothers or their aunts. I'm really seeing patients who understand more about osteoporosis and the risks there. If you've had an earlier time of menopause, we know that surgical menopause, chemotherapy-induced or radiation-induced menopause can occur before, age 40 to 45, 40 or 45. And these are risk factors for bone loss because we simply start to lose estrogen earlier and have a lower sort of threshold for doing a bone density earlier. Certain things like, again, this is why taking a very detailed history is important, both reproductive history, medical history. So any times of missing your period more than 6 months or amenorrhea, we know, again, estrogen is a significant vital sign for our bone health as well as our reproductive health. if there's been any times of being, extreme underweight or low body mass, in terms certain medical conditions like diabetes, rheumatoid arthritis, autoimmune conditions, medicines like breast cancer treatments like aromatase inhibitors, even tamoxifen, depending on when it's used, can lower the bone density. Steroids or chronic glucocorticoids or even recurrent injections for back pain or joint injections can cause lower bone density. So all to say that these constellation of risk factors need to be discussed, because if you are at risk, the medical guidelines and most, again, would agree that if you have some risk factors, 1, 2 risk factors that elevates your risk for having a low bone density earlier, you should have a screening DEXA. Again, this is a very low cost, low risk low radiation test that's widely available. And this should be offered to you, and not waiting until 65 is really not medically, as you can see, appropriate.
Is there anyone that you would feel comfortable saying wait till you're 60 or 65? What patients would fall into that group?
Yeah. So again, I really, I'm very, I feel very lucky. Like I have my own practice now. It's called Bone and Body Women's Health for a reason, that I really think the bone health is really important. Obviously, I'm also a menopause certified provider and talk about all the other health, conditions and systems involved in menopause. But I really strongly believe that, at midlife, women should be offered a bone mineral density. So really, I do that on all my patients here. I have a DEXA scanner in my office and can evaluate and interpret that, same day, right then and there, and help patients understand. And we know when we look at the national statistics, though, if you're of Asian or Caucasian ethnicity, your bone density, 50% of women at the time of their first DEXA, whether that be at age 50, 55, 60, will have either a diagnosis of meet the criteria by T-score for either osteopenia or osteoporosis. So again, when you think about 50%, flip a coin, that's a pretty high percentage already who have a low bone density. Certain other ethnicities, that might not be the same. The bone density might be as low, but their risk factors for fracture are higher, or they're just underutilization of screening or treatment rates are higher. Particularly like Black or African American women, we know that their rates of hip fractures are much higher. Utilization rates and screening rates are lower. So to me, I think that this seems like should be like a cholesterol panel or a blood pressure check or a mammogram or a pap smear. I think this is just as equally important.
Yeah, thank you. I have 2 follow-up questions. One is, you mentioned osteopenia a few times, and I'm wondering if you could just define it for the audience, and then I'll have my next question.
Yeah. So, so a large amount of women will fall in the category of obtaining their first T-score, or first bone density, or a subsequent bone density of osteopenia. And actually, the correct term is low bone mass is what we use, because I think it more aptly talks about what we're saying, the continuum from normal bone density to lower bone density. And some of this, again, is when people say, is this inevitable? Well, some of it is inevitable for some women, right? If you have a lower body mass, or you had a lower peak bone mass, or you have some of these risk factors, these things might be common. But what we do with osteopenia, again, is a T-score of -1.1 to -2.4 on that threshold of a DEXA, is we say, well, are you at the low risk for fracture? Meaning, do we feel like your risk for falls or fracture is low, or are you closer to the higher risk? And we use something called a risk calculator or variables, where we basically ask questions like, have you had the family history of fracture? Do you take steroids? What about are you having a fall? What about your alcohol intake? Exercise, smoking, etc. All these clinical risk factors and that we know, and even medical conditions that we know increase your risk for having, again, a fracture. And so that's how we kind of parse out, is it osteopenia, or we're sort of feeling like we can manage this with exercise, calcium, vitamin D, and I know we'll talk about that, and potentially prevention strategies, or do we need to be more aggressive and your osteopenia is actually closer and your fracture risk looks closer to someone who might have osteoporosis. I think I want to add one thing here, is because I think a lot of women I see come to me with a diagnosis of quote unquote osteopenia on their DEXA. However, they've had a major or a osteoporosis related fracture, like a wrist fracture or an ankle fracture or a hip fracture even. And when you've had a fracture, that sort of you automatically are really thought of as having osteoporosis, whether that's, we sort of define that as clinical osteoporosis, meaning a fracture is really something that needs to be sort of trumps the DEXA and needs to be really discussed, because once you've had one fracture, and this will be our discussion down the road, your risk of fracture is so much higher, even 7 times higher in the subsequent year. And then that risk remains elevated for many years. And then we put aging and potentially falls on top of that. And that is, again, untreated and undiagnosed osteoporosis. So we need to really categorize that in the right way so we can evaluate and treat that in the right way too.
That's very helpful. Someone had a question that I'd love for you to clarify, because she was diagnosed with osteoporosis, but her doctor said she was at a low risk of fracture. So I'm still confused about the relationship between the diagnosis and the fracture risk.
Right. So, and this is a very common question, and thank you for bringing that up. And I think that's probably because when we look at the DEXA scan, sometimes that risk calculator, and one of the ones that we use, there's many, but there's one that's more widely available, is called the FRAX risk assessment, and that's again a freely available online tool that looks, it's validated by the World Health Organization. It's country specific, ethnicity and race specific, and it has you put in some demographic variables and then other clinical variables and the DEXA, and it sort of spits out what's your fracture risk for a hip fracture over 10 years or your major osteoporosis related fracture over 10 years, and certain levels over 3% for a hip and over 20% for a major osteoporosis related fractures, again, is a sign that you're at elevated risk for a fracture. And things that elevate that risk are having a low bone density, a prior fracture. So if you don't have those and you're of lower age, like maybe women in their 40s and 50s, your fracture risk, even with a T-score of minus 2.5, might not signal that you're at elevated fracture risk. But remember, that's looking at population. The FRAX really is looking at population-based data, and the competing risk factor is actually death versus individualizing treatment, right? So again, we need to individualize treatment versus say, yes, overall your fracture risk is lower in the population, but what's your individual risk? Let's look at your history yourself. Let's look at your DEXA. Let's look at your age. And again, look at your patient preferences and your goals, through the lifespan.
Thank you. That's very helpful. We're going to come back, to this question of when you are at a doctor's who refuse to prescribe a DEXA scan. And actually someone made the point that they had it done for $75 out of pocket. So I was told that too, that ultimately this is not exorbitant if you run into a wall, but it should be covered. And so we'll talk about that. Do you have any comments about that?
I think for sure, knowing your family history. So a family history of osteoporosis, if you've lost any height, that can be sometimes signs of, of either a vertebral fracture or lower bone density in the spine. So sometimes those are clues that you should obtain a bone density. If you've had a vitamin D deficiency, or you're low in calcium, or you have one of the, inflammatory conditions like celiac disease, inflammatory bowel diseases, any of the conditions, rheumatologic conditions, that's really a key factor. Again, so I know some of the asymptomatic, it's sometimes harder, but again, this is very important for, making decisions. Actually, I would say for now, because we can do a lot to impact, and that'll be our next discussion, impact our bone density now and in the future. So I think this is a very important, and I know that there are some freestanding DEXA openings and in clinics, etc. Oftentimes they're really focused more on cardiometabolic outcomes, things like telling you you're using a DEXA for things like body composition, which doesn't always, and then when they do a bone density, they do a total bone density. And I always like patients to understand that if we put all your bones together, well, generally, that can be normal or osteopenia, but we really need to look at the bones that we really have validated, which is the hip and the spine, and sometimes the wrist or the forearm. And so we do a total bone density. We really only use that in pediatrics. We really shouldn't be using that as adult for screening of bone mineral density.
Thank you so much. So we wanted to turn to prevention, because what we don't want is women to get to 60, have their first DEXA scan, and find out they have osteoporosis, obviously. So we've talked about the DEXA scan. Can you tell the audience what other strategies you recommend for women to prevent osteoporosis?
Yeah, so I think, we've talked a lot about peak bone mass. And so, again, there are some variables and some of them are out of our control. Our peak bone mass, so all the bone that we're going to build, or I call that the bone bank, can be anywhere from 50 to 80% in terms of our genetic heritability. So when we think about that, like if your mom had a low bone density, the chances are that you might have a low bone density. So knowing that is really important. And then maintaining the bone density is just as important too. So there's a lot of discussion on like nutraceuticals. There's a lot of discussion on lifestyle. There's a lot of discussion about calcium and vitamin D. So really the basics and the building blocks are that, hydroxyapatite calcium is what bones are made of, that phosphorus and some bone cells. So it is important, calcium gets, sort of up, down, and around the confusion, but we know the basic calcium is very important. If you don't have calcium, there's a condition called osteomalacia or even rickets with low vitamin D and calcium, which, we know is there if we don't do enough calcium and vitamin D through our lifespan. So calcium, really, we look at the recommendations from the national governing bodies, and this is again for community dwelling women, women without osteoporosis, the recommendation is about 1,000 to 1,200 milligrams of calcium. And that's elemental calcium, both in dietary sources, which can be dairy sources, non-dairy sources, or supplements. Vitamin D, the recommendation again from the national regulatory is 800 international units, which is again lower than what most women I have seen need for maintenance doses of a 25 hydroxy vitamin D, which is checked in a blood test. And again, generally vitamin D levels, can be ranging anywhere from deficiency is less than 30, but generally closer to 50, 40 to 80 in most women is where that sort of ideal level seems to be for prevention of osteoporosis, maintenance of help absorb calcium, maintenance of, sort of our bone mass. Then we think about other things like, exercise. This is one where it's just very hard to study exercise for prevention. It's even so hard to study exercise for treatment. But we know from sort of our basic science that loading the bones is good. We know that fractures increase, muscle mass decreases, all things decrease if we're not active. So, and sedentary lifestyle is one risk factor for osteoporosis. So that tells us that being active is important. And it probably stimulates more bone building cells, though the osteoblasts, which actually become less active as we age. We're building more muscle mass and more bone mass as we age. And that's why we tell our teens and young people to be more active. And as we age, we can actually stimulate the osteoblast by doing repetitive motions, using our muscles and our bones for ground level forces, like doing things like running, jumping, aerobic exercise. Even walking can be helpful, maybe not to be shown as helpful as some of these other compound movements or exercises, but for the right person at the right time, those can be effective. Other exercises that can be helpful are things like balance and posture and coordination. So we have a huge movement now to do more yoga, Pilates, Tai Chi. All those are can be very helpful too. And particularly, again, for balance, as we know that changes and our muscle mass changes through the lifespan. And then resistance training is also important. I mean, I think it's hard as women sometimes, what's the best exercise to do? The reality is we have to do a mixture of these different things. So resistance exercise can be using your own body, it can be using weights, it can be using resistance bands. And again, doing like 6 to 8 compound movements a couple times a week has been shown to, again, improve bone density. And then not to mention all the other effects, right? Things like effects on cardiovascular, helps us with our fatigue, any depression, mood, all these other things are really important when we do that mixture of exercises.
So a quick question about exercise, because you're probably talking to a lot of women who are so extraordinarily busy, both taking care of parents and children and their jobs. Is there any resource you can point them to that would lay out exercise routines that are balanced, get at all the different factors you said, but are reasonable in terms of length of time?
Oh my goodness, I think that, I mean, if we should create that. I mean, I think that generally that's where I do a lot of education, and then generally, patients tell me what they do and we kind of tailor what they're doing. If they say, oh, I only walk, I'm like, well, let's add some weights are bands, or I only use 2-pound weights. And I'm like, okay, well, let's try something extra. We have to talk about if there's injuries, so it really, again, is individualized. Now, there are a lot of like community resources for, strength classes, aerobic classes. The Bone Health and Osteoporosis Foundation has a class that they have for exercise professionals like physical therapists, et cetera, to learn more about if women have osteoporosis.
Yep.
So sort of more advanced, osteoporosis, maybe vertebral fractures, maybe at high risk for falls, that they have studied the science and understand maybe modifications to exercise like overflexion or overextension, work on postural exercises. I mean, there are so many YouTube videos out there. I just was reading the Menopause Journal last night and reading, something about mind body exercises and how Tai Chi over, 48 weeks done 3-5 days a week reduced, the level of bone loss. So that's really interesting. So I went on YouTube and I saw someone who's doing, Tai Chi. So sometimes I'll recommend those things, for patients. There's some great fitness videos for like, women who are maybe over 60 or 65 to start. But I think starting somewhere with the 3 of those different buckets is very important. And then figuring out what works, what works for you.
Can you just repeat the buckets one more time for people?
Yeah. So I would say like aerobic exercise. So like that's a walking, that could be a class, that could be jogging, that could be, tennis, pickleball, anything like that. Again, all those motions, when you say, how can we work together? Remember, like a pickleball or a tennis or something like that, that's side to side motion. That's really good for lateral muscles. That's actually helpful for coordination and balance. That's not so much resistance exercise, but that's at least, again, coordination and balance in there. Coordination, balance, generally you can do these things on your own. You can balance on one foot. You could do single leg raise. You can sit to stand as fast as you can within 30 seconds. These are all ways to challenge your balance, or you can do weights, on your own. Again, this is meeting people where they are, one-legged weights, and challenge your balance with one, doing those sorts of things. Yoga, Pilates, et cetera, can also help with those. And then resistance training. And this is, I think, the biggest like question mark. And I also think this is where like a lot of people are asking questions like, do I need to lift heavy weights or light weights, small repetition? I mean, I really feel like the research is all over the map. I think to stimulate bone and muscle, the evidence is maybe heavier weights, but you also need to do the repetition. So 3 sets, 12 reps, of 6 to 8 different compound movements. That takes a lot of time, and doing that at least 2 to 3 times a week. So that's where you have to sort of sprinkle some of these things in maybe together, is what I say.
So I want to turn now to one other prevention question. Someone asked, they were diagnosed with osteoporosis at 52, but still in perimenopause. The rheumatologist wanted them to go on hormone replacement therapy in perimenopause. My question about hormone replacement therapy is that when is it appropriate to use it for prevention?
I'm so happy you brought that up. So exactly. So when we just talked about like osteopenia or even osteoporosis at low risk for fracture, we talked about calcium, vitamin D, exercise, again, alcohol, smoking, movement, all these things, knowing your family history and is very important, and all the clinical risk factors. The biggest, I think thing that we actually have great studies on, including the Women's Health Initiative study, which is in 27,000 women. Although these women were on average older in their 60s, we did have younger women studied like in their 50s, et cetera. And we know from that study and from other observational studies, meaning following women over time, that hormone therapy is indicated from the FDA, the governing bodies, to prevent osteoporosis. And we know that because when we gave standard hormone therapy doses in the WHI, again, the Women's Health Initiative study published back in 2002, they really primarily had oral estrogen, so 0.625 of conjugated equine estrogen and medroxyprogesterone acetate Provera, which are hormones we don't give as frequently or as often in sort of our bioidentical landscape or our sort of more individualized hormone therapy discussions. However, we do sort of match standard doses of estrogen to those. And using those doses, and again, all comer women reduce the risk of a hip fracture by 30 to 40%, reduce the risk of a non-vertebral fracture by about the same 20 to 30%, which is very significant, even when we compare to things like oral alendronate, which is also called Fosamax, their hip fracture reduction is on about the same order of magnitude. So it's really important, again, when we think about what options we have besides, exercising more and having enough calcium and vitamin D in our day, that hormone therapy for many women who don't have contraindications like estrogen receptor positive breast cancer, abnormal uterine bleeding, history of an unprovoked VTE or blood clot or arterial thrombus, really, again, can be a good option. And that's just what we spend. And I know this is Let's Talk Menopause. I know you've had lots of people on to talk about all the different constellation of menopause symptoms that can be helped or can be alleviated by using hormone therapy, or prevented, I would say. And that's where bone health, where hormone therapy and bone health really intersect. This is used as a prevention strategy at standard doses for women who meet criteria, who are not contraindicated. And this is a discussion about dose, duration, formulation that we have pretty much every day.
So when we move to treatment, and I know you've made the point that there is not one treatment and everyone is different. We talked about 3 buckets of treatments: oral medicine, the hormones, what you just said, and injectables. So what I'd love for you to do is, this is not going to be comprehensive right now. We don't have enough time, but I wanted you to explain, you explain the hormone bucket, although I want to talk about it after for treatment. But if you start with the oral meds and give an outline of what they are and what they do, and then we'll go to the injectables.
So, and I think we have some questions on here, like seeing a rheumatologist or seeing an endocrinologist. And I think we need to frame the discussion by, I think the treatment options that you're offered depends on who you see, especially in like 2024, is that, when we think about who treats osteoporosis, what we say in the field is sort of like no one owns the bone, meaning, sometimes it's, an orthopedic surgeon who, particularly if there's something called like an FLS or fracture liaison service that's sprouting up across the country, because the orthopedic surgeons are seeing the people who have, these deleterious fractures and don't, want to see them back again. And they're seeing that their bone density is very poor firsthand when they actually touch the bone or try and fix the fractures. So you could see an orthopedic surgeon, you could see an endocrinologist, you could see a rheumatologist, sometimes sports medicine doctors, sometimes internists, sometimes gynecologists, sort of like myself. So I think what the options that you're offered are going to depend on, who you see. And particularly, again, when we think about, using hormone therapy for osteoporosis, both prevention and treatment for women who are at low risk, most of the time, anyone except for a gynecologist isn't going to prescribe or think about hormone therapy. Their first line options, because of what they're reading in their medical journals, is, and again, the American College of Clinical Endocrinology or the ACE guidelines are really the ones that most doctors use. They're going to recommend things like a bisphosphonate, like an oral Fosamax or a Residronate, or which is also called Actonel, generally first line, or other medicines like IV injectable medicines if you cannot tolerate those, or if the risk is higher, things like zoledronic acid, or a subcutaneous option called denosumab. So the reality is, again, I think the discussion is very different based on who you see. When we think about primary osteoporosis, meaning you've never had a fracture, we should evaluate why you have osteoporosis with some blood work and lab work. And then the treatment algorithm really, for many women, starts at bisphosphonates. It doesn't have to, but for many women, it does.
Can you explain what a bisphosphonate is?
Sure. Yep. So those are medicines. So the bisphosphonate's a very large class of medicines. We've actually had it the longest. Well, we've had hormones the longest since the 1940s. But the second, class is bisphosphonates, which are basically medicines that work on inhibiting the osteoclast or the bone breakdown cells. So when we think about bone biology, we build new bone. I talked about the osteoblast or the bone forming cells, and then we break down bone. And generally, primarily, those are done by the osteoclast. And what's happening at menopause is we're having less estrogen, more bone breakdown cells or osteoclasts being activated. And thus we can't keep up with the rates of bone formation that we need to. And so what the bisphosphonates do is they inhibit an enzyme in those bone breakdown cells, or osteoclasts, to prevent the osteoclasts from breaking down, particularly on bone that's already actively resorbing. And so they have generally a half-life, a long half-life to do that. And they're taken once weekly on an empty stomach, first thing in the morning. And they're generally given for about 3 to 5 years, depending on the dose and the type that you use. And that's the mechanism of what they do. They try and prevent more bone from being lost so that your own body's mechanism can kind of kick in. They have shown good fracture reduction, both in the hip and the spine. For some women, they can't tolerate those, or they're contraindicated if they have things like acid reflux or esophageal stenosis, or if they have low kidney function, like a very low kidney filtration rate. And so again, those can be, there are options. They got some bad press, and that's a whole other lecture, from women being on them maybe too long, or having adverse events that are very rare, like osteonecrosis of the jaw or atypical fractures. So we need to use, like all of our medicines, use them judiciously, use them for a period of time where we think that we maximize the benefit and minimize the risk.
And with the injectables, because it seems like that is an alternative that more doctors are turning to. Do you generally first do the oral medicine before turning to the injectables? How do you differentiate between anti-absorption injectables and bone building?
Right.
So those are, and they can't combine them together?
Yeah. Well, interesting. I know, isn't it? When you look at something from the outside in, you feel like you could fix all the problems. And I think you're right. So when we think about like the large classes, you asked me about the bisphosphonates, which are really one of the mainstays of the what we call anti-resorptive medications, or prevention of bone breakdown medicines. And then there's a whole other class of medicines which stimulate more the osteoblast, or we call them sort of the pro-modeling and pro-remodeling agents. And those are, we have 3 of those options. 2 of them actually work on our own endogenous parathyroid hormone, or PTH hormone, that when we give these medicines, and actually they're both injectables, they're called teriparatide and abaloparatide as their generic names. When we give these in small intermittent doses, they actually stimulate our own bones to form more bone, or stimulate the osteoblast, both in the hip and the spine sites, and primarily in other skeletal sites as well, to build more bone. So to strengthen our bone density that's there, and thus then have a downstream effect to reduce the rates of fracture. They actually work very well in the trabecular bone. So really when patients have a low bone density in the spine, or when they have a high fracture risk, we use those medicines first. And just to round out our discussion, there is actually a medicine that combines both bone forming and inhibits the bone resorption marker, bone resorbing, and that is called romosozumab. And it actually works on a protein called sclerostin, which is a protein that's derived from one of our bone cells, the osteocyte. And sclerostin is sort of a bad actor. Sclerostin increases as we age, also increases as estrogen drops, and sclerostin inhibits bone formation. So it sort of works against our exercise, if you will. And when this medicine, romosozumab, inhibits sclerostin. So it inhibits the inhibitor of bone formation, and thus allows our bones to build new bone. And so there's lots of ways that when we think about the pharmaceuticals we have in this space, just like estrogen is one of them that inhibits the bone remodeling cycle, we have other ones that affect the bone formation cycle. And when we think about how we choose these options, I mean, we don't just like throw a dart, right? We talk about all the things. So if our fracture risk is high enough, meaning you've had a significant fracture, your bone density is low enough, we think, again, age is a strong risk factor for fractures. We think about using the medicines that build the bone, or the ones that are more effective first, primarily, if we can, right? We obviously have to take into account finances, patients' preference, all of these other things. But generally, the field of osteoporosis, we talk about if you're at high risk, we want to use the bone building medicines, or a more potent, what we call anti-resorptive medicine, like an injectable or an infusion, if we can.
So just so everyone knows, when we send you all the recording, we will include in the email these different treatments so you can see them on paper, so then you can search for them. Because sure. I know they probably sound like Latin to you, because they do to me too, and you need the spelling. So we will make sure to get to you.
Sure. And the resource, I mean, the Bone Health and Osteoporosis Foundation has some great, resources. Sure, every pharmaceutical company has their website as well, but they have, again, non-biased information about what these medicines are, how they work, a little bit about the clinical studies. But this is oftentimes what I spend a lot of my time talking to patients about, like explaining the medications, how they work, what the side effects are, why we think they work the way they are, why we think this medicine might be a better one in terms of, their risk or a fracture. And again, patient preference is so important. But yes, the Bone Health and Osteoporosis Foundation is a great website to start with.
Okay, and we just provided you the link to that bone health site on our website. So
Fab, you guys are on it.
I'm going to turn in 1 second to a lot of questions that we have. I want to ask you one question that I have been asked from women who, we know a number of women now. This one person in particular, 57 years old, 8 years post-menopause, years of hot flashes, no hormone therapy, just got diagnosed with osteoporosis when she badly broke her ankle. She walks into your office. Tell us briefly, you can't take us through right now everything you consider. So I want you to work backwards. You tell us the assumptions that you need to make and what then you do next.
Right. So I think the biggest thing is, so you think she said she was 56. So I think again, the fracture, as I mentioned from the outside is, important. So the ankle fracture, and again, if we get into our scientific nitty gritty here, is not always considered a major osteoporosis related fracture just because of the way that the ankle is again structured, but still important. So I would ask, how did you have the fracture? Have you had a fall or fracture, in the past? I would assess balance. I do that on every patient. That's really important because if can't balance well, I know she's, in her 50th decade of life, but some people still have difficulty balancing. So we want to make sure that the balance is improved. And then I would take like we talked about, a good detailed history in terms of risk factors that might have impacted her peak bone mass, like her family history or age of menopause, or calcium, vitamin D intake, any of those offensive medicines, conditions that we talked about. It sounds like, she's having some menopausal symptoms as well. She's a couple years from the menopause transition. I would do what we call, in the medical world here, a secondary evaluation for bone loss. So, on face value, there's risk factors like menopause, family history, and being female, but then we can also check things like your vitamin D status, your calcium, your phosphorus level. We check for things like celiac disease, if there's any protein abnormality. So we do some blood and urine testing to make sure there's no secondary cause that we can't fix, why the bone density is low. And we do find that in about a third of the time. So that's what I would do. And then we would move to, sort of treatment options, starting with the fact that she is, or in the early menopause transition, I would say, or early postmenopausal years, and having some menopausal symptoms, like 70 to 80% of women will. Things like hot flashes. I always think we ask about those, but we need to ask about sleep, other menopausal symptoms. I mean, this is, again, what is so important at the time of menopause. So sleep, vaginal dryness, mood changes, joint aches and pains, hair, skin thinning, anything like that, to make the case for maybe she would be a great candidate for something like hormone therapy, and doesn't have any risk factors or concerns or contraindications, like have she had an updated mammogram? What about the rest of her routine health screenings, like her cholesterol panel, etc. But this patient for me would be a great option to consider hormone therapy at standard doses to maintain the bone density. I don't think you gave me a T-score in her, but
what about if she's over 60, or it's been more than 10 years from menopause?
Yeah. So again,
and then the Menopause Society basically suggests that that's not the best time to start hormone therapy. How do you think about that?
Well, I think that, we have some, again, general recommendations. Again, this is population-based information. That 10 years and 60 was, based on some of the cardiovascular risk factors, less so much about the bone health risk factors. And so again, I would individualize the patient's risk. So thinking about, again, this is maybe getting a little bit deeper than we want, but, thinking about the cardiovascular risk for that person. I mean, we know, again, from the WHI that women over the age of 60 were included, and it we saw the fracture reduction with use of hormone therapy. But there are other options if we feel like, so there is a whole class of medicines I didn't mention called the SERMs, or selective estrogen receptor modulators, which are things like raloxifene, or the cousin sort of tamoxifen, which we use more in the breast cancer population. But raloxifene has been shown to prevent bone mineral density losses in the spine and in the hip, but has a fracture reduction in the spine only. Again, it's a less potent than the bisphosphonates, and maybe on the same order of hormone therapy in terms of its fracture reduction. So that might be an option depending on what the bone density and the fracture risk looks like to maintain the bone mass. I rarely would go to like a bisphosphonate in someone young, because I think in the questions, what do you do after 3 to 5 years of
Yes.
bisphosphonate use? Is we know that the bone, we know this from our very well done clinical studies, that the bone mineral density just sort of plateaus. And it's probably, again, due to the mechanism, remember, of understanding of how these medicines work. Eventually, there's no more bone to sort of fill back in, and we see that there's a plateau in the density, and then we don't see that there's an additional fracture reduction, and then concerns for over suppression of bone density start to potentially set in. So if I see a woman who's in their 50s and I say, okay, well, in 3 years, let's do the basic math, you're going to be 59, we might improve your bone density a little bit, but then what, right? And we do know for some women, the bone mineral density will be maintained for a couple years off of the bisphosphonates, maybe 2-3 years because of the half-life. But then that still puts someone at an age of 60. But I think that this case and just this discussion about marching down of time is important, because bone health is one of those things, and osteoporosis is one of those things that I still think it's in its infancy of awareness. But we need to be thinking about this through the lifespan, just the way we think about cholesterol and breast cancer, is that just because you have osteoporosis or osteopenia at one time doesn't mean it's like one and done for a treatment or a thought. It's meaning we need to be reduced. Why we care is to reduce your risk of a fall or a fracture over your lifetime. And so we need to be thinking about it that way at each decade of life, why we focus so much on the time of menopause. And then, why we think about, if you have severe osteoporosis, we need to treat that more urgently, because your risk of a fracture is much higher than someone who's maybe at the time of menopause. So that's why we have to think about it differently at every stage and decade of life.
Thank you. Okay, I'm going to run through a number of questions, and we're going to try to give as quick of answers as we can to
Sure.
complex questions. But we're
Yeah.
going to try to get as many of these answered in the next couple minutes. Is osteoporosis reversible?
I'm just gonna say yes. So it is. Yes, we can improve our bone density to decrease our risk of fracture. Yes.
Okay, a number of people postmenopausal, they had shrunk an inch, and they want to know should they get an assessment for osteoporosis?
I would say yes. I mean, height loss, 2/3 of all vertebral fractures are asymptomatic. That's why you should be measured annually on a wall-mounted stadiometer, which means something that's not that clunky machine that, you were measured at when you were a child. So, and then you should know your height and know what it was at 40. And not all height loss is osteoporosis related fracture. I mean, some of it could be you weren't measured correctly, you weren't standing up straight, there can be posture changes, there can be degenerative disc changes, that change your height loss. So it's not always osteoporosis, but sometimes it can be. But again, that's important too, because if you're losing height because of poor posture, well, let's work on our spinal extensor muscles so that that doesn't happen. Because when women have kyphosis, they're more apt to fall because you're looking at your feet, you're not looking in front of you, or you're looking at your cell phone. Don't do that.
So a number of women ask, because you've been talking about hormones, about breast cancer. We are not going to get into breast cancer on this discussion because we have had multiple menopause talks on breast cancer and around hormones and breast cancer, and the overstatement of the risk of breast cancer in the 2002 study. And I encourage you to go look at our website on our menopause talks for more information. Is there anything briefly you want to say about breast cancer and hormones right now, Dr. DeSapri?
Absolutely. Again, the family history of breast cancer does not, mean that you cannot take hormone therapy. We need to do appropriate breast risk assessments. The risk of breast cancer is increased, more with things like age, weight, etc., than hormone therapy. Even alcohol intake, the relative risk of breast cancer is higher if you have excessive alcohol intake than if you took hormone therapy. So this is, again, like you said, an overstated, misinformation area. I still think we still should be doing really great breast risk assessments. We have some great risk calculators. We have more advanced imaging that can help with those. So that's what we should do.
Mhm. So there were two questions about, let's just go back to supplements for 1 second. Magnesium. What's your view on magnesium in bones?
Yeah. So a lot of calcium supplements will include magnesium. Number one, it can sometimes help with the GI effects of calcium if calcium can be constipating. Magnesium and even vitamin D can be cofactors to help absorb the calcium a little bit better. So that's why you'll see some calcium with magnesium. But the reality is calcium can be both absorbed from food and from supplements, both in an active and then passive way. So you don't necessarily need to take calcium with magnesium. That's why you'll see some supplements don't have that. For some patients, that helps again with sleep. It helps with the GI upset with the magnesium. And so we can recommend it, but it's not a need to do.
And what about vitamin K?
Same with vitamin K. So, I mean, I think that, if we thought calcium, vitamin D, vitamin K could solve osteoporosis, like the problem would be solved by now, right? So vitamin K1 and vitamin K2 are both sources that vitamin K1 is more in our plant sources. Vitamin K2 is more in things like fermented foods. There's some evidence that 90 to 100 mcg of vitamin K2 can stimulate things like osteocalcin, which is sort of precursors to bone formation. So in some women who say, I want to do like everything in terms of like that have some small studies with some benefit, then we can add these things. But the reality is the bone mineral density benefit is very small to modest. It's not going to treat and, prevent, osteoporosis, particularly if you already have advanced osteoporosis. It can help. It can be one of the, armamentariums, but I do think that we need to caution against multiple supplements for things that sometimes we don't have the highest quality evidence for.
A question here that's important, because you said one of the risk factors is surgical menopause. And when the surgery takes your ovaries out, and this question of when is the best time to get a bone density scan for a baseline if someone was thrown into menopause at 51 through surgical menopause?
Right then, and actually there is, when you ask me about like, what's the evidence to support that? So again, most of the medical societies, including like the ISCD, which is where the governing body of, DEXA scanning and validation and how we report correctly. One of the recommendations is if you have had, early menopause or a condition where you have low estrogen state. So like an aromatase inhibitor therapy for someone with breast cancer or surgical menopause. So that would be a good time to get a baseline. And even women who are in their 40s or early 40s or mid 40s who have surgical menopause, potentially for things like hereditary breast and ovarian cancer prophylaxis, that's the time that they should get a screening DEXA.
Thank you. I have one more question to sneak in, and then we will say goodbye and do our survey. But this is a really important one. You mentioned the relevance of inflammatory diseases of someone with celiac with a family history of osteoporosis. Does that person just wait until she gets, like, what do you do for a patient like that? High risk, familiar, and an autoimmune, an inflammatory disease.
Yeah. So if she herself has celiac and things, is that what the question?
Yes.
Sorry, let me look through all of them
Yes.
here. So celiac is one of the main conditions that, because again, when we have celiac or even Crohn's disease, ulcerative colitis, the fact is we're not absorbing, those nutrients like calcium and vitamin D as effectively. And so that can mean that you can have low calcium, low vitamin D, which again are building blocks to our bones. So you really have to make sure that you're getting enough of that controlling the celiac. So interestingly, I have had some patients who we diagnose with celiac disease who have a low bone density or have a fracture. And if they follow a gluten-free diet, sometimes the bone mineral density can improve within 1 to 2 years. Not always, because sometimes again the risk is already, you have other underlying risks, but I have seen that, and that is also documented in the literature. So, but it is important to get those macronutrients of calcium and vitamin D up, and so that you are absorbing and correctly. But that person would be someone who would need a DEXA right at the time of midlife or menopause, or even earlier, and hopefully has not had a fracture. And I would think very aggressively about prevention strategies as well.
So we ran out of time. I want to thank you so much for this menopause talk. This was hugely helpful to me, and I hope our audience felt similarly. We are excited now that you're part of our team, and we can draw on you. And so just thank you very much. And I think we'll have to have you back. We appreciate it. We're going to be able to say goodbye to you. We've released the survey now, and we hope everybody will respond so we can continue to improve our offerings. And thank you so much,
Awesome.
Dr. DeSapri.
Oh, amazing, Jessica. This was so good. I love the questions, and I think just the pace of our talk was great.
So thank you. And everyone, please answer the questions. We're going to put up a link to our next menopause talk. And thank you again, Dr. DeSapri.
Good day. Strong bones.
So, we hope everyone can respond to the survey. This is our next menopause talk is with our Chief Medical Advisor, Dr. Robin Noble.